So the Bicknell Lecture is one of the premier events of our academic calendar. It was endowed by William Bicknell, Bill Bicknell, the founder and chair emeritus of our Department of Global Health. Dr. Bicknell endowed this lectureship to provide, quote, a periodic but regular infusion of iconoclasts and original thinkers who will bring ideas to students and faculty that stretch, upset, stimulate, and leave us with renewed energy and commitment to make a real difference in the lives of the poor and underserved. I will underscore, although it's not underscored in the quote, the word upset. That was intentionally part of the point behind the Bicknell Lectureship. Professor Bicknell was himself a tireless advocate for underserved and vulnerable populations, and we are glad for this chance to honor his memory today, and we're honored to have with us his wife, Dr. Jane Hale. Professor Bicknell used to tell his students that the first step in public health is simply to listen. I think his advice rings truer now than ever. In these divided times, it seems to me that listening is the first step to tackling the many challenges we face. Challenges that divide us, like gun violence, climate change, and the opioid crisis. Today, we're going to listen to three leaders in politics and media. They're going to discuss how we can engage in meaningful dialogue, even amid polarization, to advance progress on issues that affect health, and I very much look forward to hearing from them and learning from them. I'm going to turn the podium over today to the intellectual architect of today's panel, Professor Rich Feely. Professor Feely is an associate professor in the Department of Global Health. He also served as the chair ad interim of the department. This session today was very much Professor Feely's idea and very much his conception. Rich, thank you for doing this. Welcome.
Thank you, Sandro. And as one who worked for and with Bill Bicknell off and on for 40 years, it's a special pleasure to be up here with the Bicknell Lecture panel. But I have been increasingly troubled personally by the difficulties we as public health professionals seem to have in communicating across political divides. It would seem that don't we all share an interest in longer and healthier lives? Why is it so hard for us to talk and negotiate around the substance of public health interventions? And so that's why I suggested the three members of this panel, because I think they bring us a perspective from both sides of the political divide and also from the objective position of a reporter on an extremely important public health event in our nation's recent history. So I'd like to start with Brandi Harless to my left. Brandi is a graduate of the School of Public Health from a few years ago, we won't say how many, who worked in both global health and domestic health, helped to run healthcare programs in her home city of Paducah, and in November of 2016 was elected the mayor of Paducah. And when I heard that, I went, one of us got elected mayor in Paducah? What does she know that we don't know? And Brandi, that's where I'd like you to start.
I don't know that I know anything new. I would like to say that being on the stage that Bill Bicknell shared in my class, some of my classmates are in the room, and this was the room where we had our lecture with him. It is an honor to be on this stage because as I was speaking with some of my colleagues and my great friends about him weeks ago, I realized that the things that he said, actually, I have taken to be my truth. And one of the reasons that I firmly believe that I was elected was because I was willing to do some things that Bill talked about. And that was to ask hard questions. It was to confront the status quo. And my entire campaign, that's who I was to my community. And you never know when a community is ready for that. I don't know that there's any legitimate scientific way to know if a community is ready for someone to stand up and do that. But I thought it was time to try. And for me, it was just starting. I decided to just start and see what happened. So to set the stage just a little bit for the rest of the conversation, let me paint the picture of Paducah for a minute for you, if that's okay. Feel free to tap on this chair when I'm ready to move on, okay? So Paducah is located on the western part of Kentucky. I like to say we sleep 25,000, but we serve almost 200,000 because we are a regional hub for our region. So there's 9 counties that drive into Paducah for healthcare, for work, for shopping, for all of the things that you can imagine that one needs. And so we serve quite a few people with a pretty small tax base. Paducah has also been designated as a UNESCO Creative City in 2013, and that has been an honor that we've taken. We were the 6th city in the USA to be designated as such, and we take that we're very proud of that. So I am firmly in the belief that Paducah itself was in a transition period. And for me, being back home, I didn't mean to be back home. It was actually an accident that I moved home. And when I finally decided to put my roots down, I decided that I was running out of ways to make an impact. And I was running out of ways to make the kind of impact I wanted to make, which was what this school taught me. That was on a population level. And when I started to realize that in elected leadership, I had the opportunity to make an impact for the entire population of my community, it really pushed me in that direction. But I also realized that the things that Bill taught me, and I'll be honest with you, I wasn't giving him the credit for the source of this permission, but I realize now that he gave me permission to ask those tough questions. And so people in my city started to see something different. They started to see that there was an opportunity for leadership to challenge what we were doing and challenge the way we had been thinking. And so I ran against an incumbent. She had been a commissioner for 6 years. She had been the mayor for 4. She was very well known in our community, and I won by 61% of the vote. In 2016, keep in mind. It was a nonpartisan seat, so that was very important to me. I had been the vice chair of the Democratic Party in Kentucky, so there was no doubt that people knew what party I was affiliated with, but I was very, very intentional about honoring the nonpartisanship of my seat. So when partisanship or politics started to come into play, I would set the tone very quickly. There is not a Democrat or Republican way to pave a street, and we're going to have this conversation as a community, not as one party or the other. And for me, that was crucial to set the stage for the kind of conversations that we've had now, a year later, in my community. And at the end of the day, that's why I think we've all probably seen the kind of shift towards the conversation is that cities are our future. And I firmly believe that now more than ever because I've experienced for myself, we can take away the bipartisanship and we can talk about what's really in front of us and look our neighbors in the eye and have our conversations. So that's been my experience, and I think that attitude was something that my community was ready for, which is why I think I was elected.
Okay, well, we're going to come back to what you said during that campaign that convinced 61% of the voters. But I want to go next to our guest, Shari Rudavsky, who's a reporter for the Indianapolis Star, but has also written for the Miami Herald and is a freelancer for the Globe, so I guess she knows something about our fair city. But she was the reporter who covered a very interesting public health incident here 2 or 3 years ago when a cluster of HIV cases were identified in rural Indiana. And that created great concern, particularly in a state where what to us public health professionals would be the obvious answer, which is they're getting it from sharing needles, let's have a needle exchange program, was not legal. And so I've asked Shari if she would describe just what happened. What was the chain of events that led to, and she'll tell us what actually did happen.
Okay. Well, thank you. I appreciate that. I want to start off by saying that having lived in Boston and then moved to Indiana, I know that sometimes people in Boston have set ideas about the way people in Indiana think. It's not a blue state. It's often considered to be a red state. It's, you know, the home state of our vice president and many members of his administration. So I want to start off by saying when I was asked to do this, I went back into our newspaper's archives to find the first time we had any mention of the phrase needle exchange. And it was a story, and I'm going to quote from this, and I'm going to ask if anyone wants to guess what was the date on the story. It said Indiana should begin programs to let illegal drug users exchange used needles for clean ones as a way to slow the spread of AIDS, the Indiana AIDS Policy Group has recommended. The committee is urging the health commissioner to begin working on ways to start such exchange efforts. At the same time, the committee said the state needs to combat a shortage of drug treatment programs because needle exchange programs are a tool to encourage people to get help. So anyone want to take a stab at what year this article appeared? Aha, a hand in the back. Well, okay, you give us more credit than perhaps we deserve. It was 1992, though. So as long back as 1992, in Indiana, people were talking about needle exchange. And remember, Brian White, that's a name that most people are familiar with. He, too, was a young Indiana child, and that whole story got played out in Indiana. So, and actually it turned out that, and I sort of had heard rumors about this. I've been at the Star for about 12 and a half, 13 years. I'd heard rumors that there was an underground needle exchange program that was operating in Indianapolis. And I think there probably was one, but it was very low-key and very sort of small business. Nobody talked about it. You couldn't really track it down. I actually tried maybe about 5, 6 years ago to see if I could track it down, and people weren't sharing numbers. It was very underground, very under the radar. So in 2014, this is a year before the HIV outbreak, a Democratic state legislature, a Democratic representative proposed a bill that basically would say if you had hepatitis C, there was, hepatitis C numbers were certainly growing in our state as they have all over. So if you had hepatitis C, you were required to tell others that you had put at risk, either by sharing needles or sexual contact. You were required to tell people that. And also the bill said, let's study the feasibility of exchanging a state needle exchange program. The House, the Indiana General Assembly, one of the chambers, the House passed this bill by a vote of 83-10. The bill got referred at that point to the Senate Corrections and Criminal Law Committee. At that point, it was co-sponsored actually by a senator who was a Republican. She was known for very conservative. She was a former nurse. And she was known for very conservative ideologies in certain areas, very much against sex ed, very much against abortion. But she co-sponsored this bill. The bill never got out of committee. So fast forward a year. Okay, so now we're in February of 2015. And the first indication that we in the press get that something is amiss is a press release from the Indiana State Department of Health. As I'm sure you all know, state departments of health monitor HIV cases, looking for kind of unusual blips for just this reason. So here was an unusual blip from a rural area in southern Indiana, Scott County. 26 people were diagnosed with HIV, and there were 4 preliminary cases. And the health officials, when I spoke to the health officials, they said, we are seeing cases increase exponentially. A month ago, they had only had 11 cases diagnosed. And this was a county that in most years saw fewer than 5 cases of HIV. So they knew that something was up and it was odd. And at that point, they basically started saying this is connected to people who inject drugs. They knew, they obviously went down, they did surveillance, they noticed that I think actually it was all maybe but one were confirmed substance users. And at that point they were using a prescription painkiller known as Opana. They would crush it up, and it was supposed to be abuse resistant, but substance users are pretty inventive, and they have found a way around it. And the health officials at that point started talking about the importance of sharing clean needles. Now, I will say at this point, I didn't realize that I had never been to Scott County. I had been by Scott County. It's between Indianapolis and Louisville. It's about, you go through it, and Austin, the town of Austin, which was the epicenter, is about 4 miles east of the highway. And when I didn't go down there at this point, I just wrote that story because it was weird and we didn't really know what was going on, and we couldn't, it wasn't yet a huge story. I will say that when I went down, and as it became, what became apparent was this was a very ingrown community of substance users. There were tales later on, and you may have all heard this on the national media or maybe even in the Star, but there were tales of families where grandparents would share with children who would share with grandchildren. So there was kind of an attitude that I don't need to worry about who I'm sharing my needle with. I can't get AIDS. That's something that happens somewhere else. It happens to people who are homosexual. It happens to people. There are all sorts of myths and stereotypes about who gets AIDS. But I'm sharing with Josh, who I've known all my life, and there's no way Josh has AIDS, so I'm safe. Well, the first thing the public health, the state health department did at that point was to start a campaign. You are not alone campaign to get out word about the importance of not sharing needles and clean needles. And I think at this point, sort of tracking it back, there was probably some back channels discussions about, hey, let's think about a needle exchange program. At that point, our governor was Governor Pence, who had been on the record several times saying that he didn't approve of needle exchange programs. He was afraid, he belonged to the school of thought that needle exchange was encouraging and endorsing drug use. So he certainly wasn't coming right out and saying, let's put this in place right away. So as March ticked by, the number of HIV cases in Scott County continued to rise. By March 20th, it was up to 55 with 13 preliminary cases that were almost definitely going to be confirmed, and the CDC was coming down. The CDC had never seen anything like this. I mean, it was pretty big news. I think, and again, I think there will continue to be these back channel discussions. Can we talk about needle exchange? This is what the public health people believe is really important to do. This is critical. We want to stop the spread of disease. It's not encouraging drug use. It's harm reduction. It's harm reduction. So I'm going to back off a little bit for public health just to give you a sense of what was going on at the exact same time. There was also a huge debate about the Religious Freedom Restoration Act. I don't know, does anyone remember that? That was another time when Indiana had a fine moment in the National Sun. There hadn't been a lot of backlash against it as it's moved its way through the House and the Senate. And just as Pence had already said he was going to sign it, and that's sort of when, pardon the expression, all hell broke loose. And people started saying, what is Indiana doing? How can they do that? All of these major companies, so Pence, all these major companies like Salesforce, Cummins, local hospitals, the Indiana Chamber, all start pressuring Pence. Meanwhile, Pence is also, so he's dealing with this, and he's dealing with the biggest HIV outbreak in a rural community that the United States has ever seen. I mean, I must say, it was not, I can't imagine that was a good week for Governor Pence, and I can't imagine it would be a good week for anyone. So March 23rd, the RFRA Act passes, and March 25th, the governor held a press conference, and he says at the end of it that he's thinking about declaring a public health emergency. And at that point, the question is still, okay, well, there's going to be a public health emergency in Scott County. Is he going to go against what he has said and declare a needle exchange, which everyone thinks is the best route to halting this? So that same day, again, the Indiana House held a 3-hour hearing on needle exchange. And on that same day, I mean, think about all these pieces that are going on. I'm going to refer to my Kentucky friend to the right. That very same day, the governor of Kentucky signed a law allowing for needle exchanges. So we're starting to see more and more movement. And that day, on March 25th, was the first time that a deputy for the Indiana State Department of Health, who incidentally is now our FSSA secretary who oversees Medicaid, appeared in the House, and she said, Dr. Jennifer Walther said, what we're considering, she said, okay, maybe Pence is going to think about needle exchange. She's thinking about it. What we're considering is a surgical strike for the areas affected. He's opposed to it as a systematic 92-county solution. So you could see that the government, the administration was moving closer and closer to it. The next day, the governor signed the RFRA Act, and that same day he also okayed the 30-day emergency response plan and said that as part of that, Scott County could start a needle exchange program. As he did that, he said, he made sure that people understood, I don't believe effective anti-drug policing involves handing out drug paraphernalia, he said. And then he warned that if the legislature sent him a bill with approving broad-based needle exchange, he would veto that bill. So even as he's saying it's okay for Scott County, he's still saying, I'm not all in, guys. I still have some reservations. 4 days later, the House approved a bill that basically allowed counties, it set up a system by which counties could make a request for the state health department to declare that they had a public health emergency, and then they could each set up their, they had to go through a particular process. They had to have a county commissioner approval. They had to show that they had a public health emergency, and then the health department had to approve it. But then it was open to any county to ask for a needle exchange. So all these folks went down. I will say that it wasn't just about the needle exchange. Sometimes that's what gets focused on when we hear about the public health emergency. They put in a lot of social services down there. They brought a couple dozen state health officials to help out. The CDC was there. They're trying to do contact work. They're also trying to help. This was an area that was incredibly poor. And I will be honest and say, with my biases, when I went down there, having heard about this, I thought I would find something like Appalachia. But it actually wasn't like Appalachia. What's fascinating about the small town of Austin, where most of these cases took place, is it's really a small town. And you drive down the main street of Austin, and it's shuttered storefront after shuttered storefront after shuttered storefront. And I always wondered, perhaps not incidentally, like 4 of those shuttered storefronts were chiropractors' offices, 2 were dentists. And you speak to some of the physicians, there was only really one physician who served the area, and he said that when he first moved there, he was shocked because 18-year-olds would come to him and say, okay, I need you to fill out my disability paper. And he would say, why? Well, what's your disability? And they would say, well, I'm 18, I need to be on disability now. And it was a culture that, when you hear about it, was a culture. There had been a big canning plant that had closed there. It was a culture that really, a large portion of the population of downtown Austin was substance users. And that was kind of their career, if you will. And as I said, it gets back to this was what whole families did. So anyway, so when the state health department went in, they provided them with all sorts of services that they had never had. Fortunately for Indiana, a couple of years back, we had put in place the Healthy Indiana Plan, which was a precursor of a kind of a Medicaid expansion plan. So a lot of these people were able to get health insurance for the first time. They were able to get ID cards. They had never bothered. It was a small town. They didn't have to necessarily drive, or if they did drive, they didn't necessarily have to have licenses. So they all got ID cards. And a month after the program started, Dr. Walthall, the same person who had said that, this is only a surgical strike, she said the State Department of Health and the community partners are thrilled with what the Scott County Health Department is doing with their needle exchange. They've never done anything like this before, and they've put together a plan that works for them. So this, that same month, the Director of Legislative Affairs for the Indiana State Department of Health testified in front of the Indiana General Assembly and said, again, talking about the importance of needle exchange programs, this is a brand new concept for the state of Indiana. I think the administration would be open to having a conversation. Sure enough, the General Assembly passed a law allowing for needle exchange programs, as I said, at the end of April, and Pence signed it. He continued to approve extensions until that point. He approved extensions of the public health emergency. Actually, last year, we have a new governor, Governor Holcomb, who's also a Republican. He said one of his pillars was changing the way needle exchange is done. so that instead of having to go through the Indiana State Department of Health, which he thought was too arduous for some counties, now counties can just basically decide on their own that they want to do it. So there's been a liberalizing of how needle exchange works. So I'm not really sure what, I think the message is that sometimes with public health, even people who you think might be ossified in their beliefs can be persuaded by the experts to do what those in public health say is the right thing. So, and I think actually, truthfully, I think it's an important story for people to think about when they think about how you start off on two different sides and maybe you move to a center where no one's incredibly comfortable, but at least you're moving forward to a point where people are getting helped. So.
Shari, thank you. And I think it's significant that things changed, but we had to have essentially an unprecedented outbreak at the local level before people began to rethink the laws that govern what to us public health professionals looks like a rational harm reduction program. But I think sometimes we can be a bit tone deaf. Perhaps we sing to each other so much that we don't realize we're out of tune. And I'd like to introduce our next guest to remind us that sometimes you have to sort of look at what we're saying from the outside and think about its implications before we can really make a change for public health. Josh Archambault is at the Pioneer Institute as a policy analyst, and I think he'll tell us a bit more about where he's coming from, but I've had a chance to talk to him, and I think some of his observations are very much on point.
Well, good afternoon. I really appreciate the opportunity to participate in the lecture, but also value this important conversation. So I wanted to start with a question and then follow it with a brief case study that I think will help illustrate my perspective on how we can all be more effective in improving health. So would you raise your hand if in school you learned that prohibition largely failed in this country? Okay, most folks. Well, that's kind of right. It's actually the federal government action that failed. And it can be strongly argued that the efforts of private philanthropy left a long-lasting cultural impact that should be the envy of the public health community. Two evangelical Christian brothers, Arthur and Lewis Tappan, born in Northampton, Massachusetts, and unknown to almost everyone, played a tremendous role in solving multiple societal ills in the early to mid-19th century. The Tappan brothers are most well known for their role in abolition. They helped fund the legal team that included a local gentleman, John Quincy Adams here, that represented the slaves for the Amistad. But they had many causes, including addressing the issue of overconsumption of alcohol due to its negative impacts on society. So let me paint the picture for you. Alcohol consumption was a serious societal problem. Some studies put average consumption for adults at upwards of 8 gallons a year. Media accounts from the time period record that many businesses closed on Mondays or opened very late due to the heavy drinking that took place over the weekend, and many businesses observed 11s, a daily break for a drink in the morning. And alcohol-fueled street fights were so common that many people walked around cities with bloodied noses and cuts on their face. At the White House, during the public receiving line for the Inauguration Day open house for President Jackson, the crowd became so out of control after enjoying the rum punch a little bit too much that many staff feared that the public would destroy the china, the artwork, and even had fears for the structure of the building. It got so bad that the president had to escape out a window. Staff finally decided to move all the alcohol onto the White House lawn to draw the crowds out of the building, and it worked. The Tappan brothers listed many reasons why they were concerned about the harmful effects of drinking. So these two brothers funded, largely just the two of them, local temperance societies, and many Americans signed a pledge to give up drinking. To give you a sense for how big of a movement it actually was, roughly 2% of the population signed. It may not sound like a lot, but it's far bigger than the Sierra Club or the NRA today. The failure most of us learned about in school was the federal government's attempt at prohibition, but the impact of the local movements does appear very, very strong. Some have put the cut in drinking to roughly 50 to 70% on average reduction. Of course, there are many moving parts at the time in the country, but the end result was lasting and impressive. Now, the Tappan brothers should teach us an unexpected and perhaps surprising fact in hindsight, given their possession on alcohol. But government intervention without cultural change can always be repealed. So as a way of context, I work at 2 think tanks, and I specialize in healthcare and welfare reform. I've had the privilege of working with policymakers in over 24 states in very different ideological and political environments. I've also worked at the federal level. I used to work for a governor here in Massachusetts in a state center. Needless to say, I've heard arguments for and against health and public health issues in red, purple, and blue states alike. So here, what are my takeaways from that? How do we bridge this political divide? I wanted to start with a couple PG versions of some negative sentiments that I've heard in my career to talk about public health initiatives, so we all have the same baseline to work from. So these are iterations of what I've heard. They think they know it all, yet they're so out of touch with real Americans. They say they want to help, but they just make things harder. Is their real goal to shame us? These city elites have money to preserve their choice while eliminating it for us. They say they care about poor people, but their ideas just cost us money. Ever heard of personal responsibility? Do they really think we don't care about our own community? So to be fair, of course, these sentiments are not just for the public health community, especially the skepticism of non-locals, but they're very common ones. In fact, I'm aware of them in my own work in probably about 15 states. Coming from New England, that's the bias that I face. I always love when I'm in a hearing and the first question I'm asked is, when did you arrive and when are you leaving? So where do we go from this if this is a common sentiment that we see? How do we be more effective in talking to a larger swath of the population? I thought it'd be helpful to pose a couple of mindset or gut checks or questions that I've learned in my experience and then give you just some really practical tips. So the first question to ask, do we respect value-based positions, even when they're not our own? By this I mean, do we always find the underlying values behind a position if for those that don't agree with us? So is it a concern about ceding control, maybe especially to a government official? Protection of a family structure or community value, or maybe just fear of trust based on a previous bad experience of working with an outside organization? This framework or value-seeking exercise can be very helpful when working in an area that you're not from, or working with somebody that you disagree with. I'm going to go out on a limb here and say I'm confident that President Trump is probably not the most popular president in this room. But if we take what he says and boil it down to the underlying value language, really boil it down to its foundation, I've heard similar sentiment expressed by liberals and conservatives alike in my travels around this country. Unfairness, inequality, a stacked deck, in many ways echoed by Bernie Sanders. So do we respect the value-based position for those that disagree with us? Do we ascribe positive intent to others' concerns? There's a real reason they're concerned about their change. I'm sure Vice President Pence would say that. And I suspect if we thought long and hard about possible unintended consequences or precedents being set by any change being proposed, you could come up with an outcome that you don't support. One of the most valuable lessons I picked up while working in government that's really stuck with me is that under any change or reform, you have to first start by thinking, how would a bad actor take advantage of this? I can tell you this is rarely done in public policy. So find that outcome or outcomes, take that as your position of concern. It may be the one that the other person on the other side of the table has and maybe hasn't fully articulated. Don't defend your original idea at all costs. Work backwards from that poor outcome that you're trying to prevent. This will likely change your approach and probably your original idea to begin with. So do you ascribe positive intent to others' concerns? Do you think nerds should win just because they have data or evidence-based research? In fact, in many communities, they've been badly burnt by data and research in the past. Data can be a weapon, but it can also undercut your work if not properly deployed. Now, trust me, I love data. Yet in my own work, my education and training can be a liability if I'm not careful. Many citizens rightfully suspect or excuse me, are rightfully suspicious because they see in the news settled science or data flipped on its head every couple of years. Let me just give you some seemingly random examples of that. When you feed your kids peanut butter, completely flipped between my two kids related to allergies. I bet you most people thought that was settled by data and science. Or the recommendations on when to use hand sanitizer or how often to use it, the use of antibiotics. I could go on in these very practical examples. Our work is not isolated, and even if we think it's unrelated, and it might be, you have to rethink your stance. We're not operating on an island of our own. We should not pretend to be. So use research and data only when needed. Next and final question. Do we think freedom is a real choice, even if you don't like the outcome? Think about it this way. By what right do you have to impose a standard or policy that supersedes someone else's choices if it's taken away under that intervention? I'm going to say that one more time. By what right do you, or do we, have to impose a standard or policy solution that supersedes someone else's choices if it's taken away completely under the intervention? If your answer is some variation of, even if really mild, we know what's best, then you probably should pause and think about how you're going to move forward. Or if it's some iteration of, I don't think they can fully understand and insert any sort of reason because of poverty, because of blah, 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 you should pause for a while and think about how you're going to move forward. If I don't define your ideas are right for me, why do you get to define it that way? Especially if you're using the mechanism of government to have an intervention. Now, this might sound like a discussion more well-suited for the Department of Philosophy, and perhaps it is, but its practical implications of our answer to that question really should influence our approach to improve health. Okay, so now that we've had these questions that I've learned in my career, I want to give some really practical tips. The first one is going to sound awfully political. Message test everything. In other words, do public polling on your ideas, including what to call it and how to talk about it. Our gut of the best way to talk about reform is often wrong, or at least not the most effective way to do it. Isn't our goal to be the most effective? In my experience, and we do a lot of public polling around the country in my work, there are strong regional differences. So you should look for messages that work across the political spectrum and across the country. The second practical tip is speak American. By that I mean, if you're using acronyms and more than 3 data points when you talk to the public, you're probably doing it wrong. My rule of thumb is if I don't think I can teach my extended family how to give my reform pitch, then it needs to be reworked. This is not to say there's not real detail or substance to the reform that you're working on, but our goal should be to explain it in such a way that it's accessible to as many people as possible. The final one is finding an unexpected champion. So for this, probably the most prominent example I can think of is C. Everett Koop, under Presidents Reagan and Bush, a committed evangelical Christian, former pipe smoker who embraced condom use for AIDS, to fight AIDS, and made one of his main platforms to end smoking. Unexpected champions can be some of the most effective advocates for change. Finally, I just want to spend a moment talking about perhaps the part of this will make you uncomfortable if I haven't already. A frequent blind spot that I observe in the public health community, the role of government. I'd encourage us all to think outside the government box first. When talking about a public health issue, how often is government your first answer or only answer in response to the problem? I humbly submit that a good rule of thumb is a government-only solution should be tried only after you've exhausted all other options. Why? An oft-quoted remark from former Congressman Barney Frank here from Massachusetts says this: government is simply the name we give to the things we choose to do together. Sounds so nice. It's intended to capture this positive intent of government collective nature. But I think it's completely tone deaf to the low-income mother frustrated with a failing government-run school that her kids are trapped in, or government-run healthcare program that puts disabled kids on wait lists for Medicaid services, or a government-backed criminal justice system that jailed her son, who's innocent, or a government that's often run by politicians that are frequently found to be corrupt or untrustworthy. It should be obvious any government action does not take place in a vacuum, but many of us don't act that way. Now, perhaps some of you don't think about government intervention in this way. I suspect many view it instead on riding in on a social justice white horse of government. But in my experience, I'm telling you, many people in this country don't view it that way. They're frustrated with unfulfilled promises. Yet, I've observed often in my career, the public health community shows up with a toolbox with 10 tools in it. They all look similar. They all use the policing power of government to make it a reality. I do question the long-term value of such a uniform top-down approach. In short, think outside the government box first, as the Tappan brothers did. I want to close with just one last short story. I remember listening here locally in Massachusetts about a debate on a health care bill in 2012. And a large part of that bill, and loudly cheered for by the public health community, was a $60 million fund for prevention and wellness in the state. Advocates, and I remember talking to a bunch of them, were very excited about the fund. Yet I overheard a serious conversation behind the scenes between two well-placed lawmakers in the House that they were excited about using the funds to build bike paths in Wellesley, Massachusetts. For those of you that don't know, Wellesley is a very affluent community in the suburbs. Something that often goes overlooked in public health discussions is that government taxpayer funding always has trade-offs. The same dollar can't be spent twice. So we have to ask, is spending money on bike paths in Wellesley more worthwhile than early childhood education, or higher education, or anti-smoking education, or helping the homeless, or helping the disabled? To me, fair or perhaps unfair, this story illustrates the disconnect I often observe in the public health community. On the one hand, good intentions for sure. But on the other, large gaps left for unintended consequences. A failure to anticipate them, a lack of foresight to put in place mechanisms to stop bad outcomes when they arise, or quickly shut down an ineffective program, largely because the toolbox only carries government tools that requires a steady stream of public funding. This can create, not always, but can create a cycle of wasteful and ineffective work that undercuts future efforts to improve health. So, assume good intent by those that don't agree, message test, find an unlikely champion, prioritize well, think outside the government box first, and we will all be more effective. Thank you.
Thank you very much, Josh. I'm going to ask a couple of questions, and then I want to open it up. I'm really pleased so many people schlepped through the slush to get here, so I want to give you a chance to ask questions. But I want to ask the one person on the stage who's actually managed to get elected. You know, how do you manage to talk to, you obviously got 61% of the community. You presumably didn't have a large fund for polling. How did you figure out, you know, what things would reverberate with your voters, and in particular, what public health issues would attract sympathy?
Well, I want to say that a lot of the things that Josh said is the reason why it's important for us to be asking this question of this seminar tonight. The tension that gets created between the differences of our thinking is where we come up with the best solutions. I firmly believe that. And it is very important for us to figure out how to have these conversations when we disagree. That, first and foremost, was the way that I approached my campaign. I welcomed opposition, I welcomed people with different opinions than me, and I listened a lot. Listen, listen, listen. And for me, that's how I learned what the issues were in my community. I didn't know them. I listened to the 10,000 people whose door we knocked on. I listened to people's concerns. I tried to connect as much as I could with my own experience. So at any moment that I could, that someone mentioned something like our community, our city government is not business friendly because our inspections department is too strict. That obviously is a public safety conversation, which is a public health conversation. And so at any time that I could tie those issues back to my own knowledge and expertise, it really worked in my community. And talking about evidence and data, I totally agree. It does not need to be on its own. It needs to be considered with implementation, with how we practice what the evidence says. And for me, it was about engaging in a conversation. And I would like to share one story. This is not about the campaign. This is about governing now, because I've been doing this for a year. We've been talking about, in my community, passing a comprehensive smoking ordinance. We have a smoking ordinance that bans smoking in restaurants, but we're talking about doing a comprehensive ordinance, which some places and research has demonstrated that it could have a real impact on the incidence of smoking rates. So we're talking about doing this. We will be the first city in Kentucky to do the comprehensive version, which means it includes public parks, workplaces. There's a list of them. One of my fellow commissioners and I were talking about this. And he said to me, well, you know, that information about smoking and the harms of secondhand smoking is just fake news, right? So in that moment, this is what I literally said to him. Commissioner, I spent $100,000 at Boston University to understand that this is a real issue and that the evidence is pretty clear. And so while he wanted to say to me, no, that's just fake, that's not real, that's where the evidence was so important. It was important for me to be able to look him in the eye and say, this is why we're going to do that, because we know on the other side of this we can have a real impact on our community. Now, going back to the question of the reality of all of this, and I am pretty sure that Bill Bicknell would say this if he were on this stage, our rights always butt up against each other. They always do. And in the case of smoking, the conversation, we have not passed this ordinance. We've introduced it. It has its first reading. The conversation now in my community is whose rights butt up against whose other rights, right? The rights of smoking versus the rights of not having exposure to secondhand smoke. That is a dynamic world and a dynamic conversation. There is not a perfect, beautiful academic answer to that question. That is an public engagement, a tough conversation in the trenches question. That's why I'm becoming more and more a believer that this stuff has to happen on the local level. That message testing across populations, it's almost impossible because you have to know the locals. You have to know what's happening on the local level. You have to speak the same language. I can't use the jargon of public health to talk to my citizens, not because I think they're not smart. That's not why. They're very smart people. It's because I paid $100,000 to know that language, and they didn't. And so to come to the table with an understanding of reducing the jargon and talking about this from a common sense perspective to me has been key. And not being afraid to go there. We recently recently added gender identity and sexual orientation to our human rights protections locally. This was a very challenging conversation for my community, very challenging. But I feel obligated and responsible to help to facilitate and set the tone for my community that we can have that discussion with dignity and respect for one another. And so at that commission meeting, there were 300 people piled into City Hall, some on one side, some on the other. And I knew that my job was to create the environment by which we could have the conversation. In the end, it passed 4-1, but the majority of people walked out of that room feeling heard. And without the divide that we see in other places. And I firmly believe that the way that happened was because it happened on a local level. At the very beginning of that meeting, I looked everyone in the eye and said, I'm glad you're here. I want to ask you to take one moment to look around this room and to look at your neighbors, because these are the people you live with in your community. Let's remember that when we get up to that podium and start advocating for our cause. And every single one of those people came to that podium and demonstrated respect, even if they weren't in agreement. That is, for me, the most important part of my job as mayor. Not to pass controversial policies, not to change all the lives and try to save the world. But for me, it's demonstrating how this democracy is supposed to work. And I think we have to do that on a local level, number one. But even when we talk about the social media conversation, I'm a big Brene Brown fan, if you haven't already picked up on that. And she says it's hard to hate when you're up close. This is about humanizing each other. And it's about realizing that what Josh said and being able to come to the table and hear, listen to someone who is coming from a different perspective and take that into consideration and mash all that up for the better outcome. That's what we're after. It's not whether I'm right or wrong. It's the engagement that matters, and it's the engagement that gets us to that point. And this is becoming more affirmed to me as I experience it. When I enter in these conversations, I think I know the answer. I think I know the end result. But as long as I'm willing to go into the process and I'm willing to have the conversation, I always come out on the other side with a better solution. That has been reaffirmed in me over and over again for however many days I've been in office now.
Thank you.
You're welcome.
Shari, can you apply any of Josh's principles to what you saw happening in Indiana? And I think particularly, I'm a secret admirer of C. Everett Koop, but I mean, but was there a coup in the Indiana state government? Was it just that people were aghast at this collection of cases in a place they never expected to see them? What was the turning point?
Well, I mean, I know many of you saw Dr. Adams, or Surgeon General Adams, when he was here last week, I believe it was. So again, this is something that I've never had confirmed on the record, though I've heard kind of buzzing about. I mean, Dr. Adams was a trained anesthesiologist. I think in some regards, he was an appointee of the governor. He was an appointee of Governor Pence. But I'm not sure that his politics or his approaches, especially when it came to public health issues, were 100% in line with the governors. I've never heard Dr. Adams. I've never heard Dr. Adams, for instance. He usually ducks when it comes to where he stands on abortion. So he is certainly not outspoken on abortion the same way that the vice president or the then governor was. But I think that all along, Dr. Adams and those who were trained medically were pushing the governor as much as they could to think about using needle exchange. And I think they were saying this is what the experts think. This is what the experts think. I know that you don't approve of needle exchange as anti-drug policy, but sort of shifting the discussion to thinking more about harm reduction rather than anti-drug, and that might not have been a divide that a non-medically or public health trained person thought about, the concept of harm reduction versus anti-drug. It's a subtle thought. I mean, I think the one thing, and where that comes in with what Josh said, is it's taking the time to educate, but not educate in a paternalistic way, but to hear where the other person's concerns and objections are coming from and explain where your side is. And I do think that the optics, I think if the state had held steady at 26 HIV cases, we probably wouldn't have needle exchange today. I mean, I think that is a reality. I mean, I think the optics also played a role. You don't want to be the state that has 300-400 HIV cases and you've done nothing that you've failed to take the one step that the CDC is saying could be the most important in halting the epidemic. So,
thank you, Shari. And I think Mayor Harless and I, in a discussion, I think language is important, and I think we easily lapse into our own public health language. And I think the point you made the other night, Brandi, that if you talk about gun safety, it's a very different issue than if you talk about gun control. And that, we all think in terms of social determinants of health, but that may be a buzzword that prevents us from talking about early childhood education or nutritional supplements and things like that that may actually be good for public health and that others would engage with. So I mean, we can talk across the divide, but I think we have to think about how we talk. And at this point, I'd like to open it up to the audience for questions. This is not your usual public health panel here, folks, so please take advantage. Yes, sir.
Thank you for everything that's been said so far. This is probably like I guess it's a controversial night, so let's just go there. My issue isn't with talking with people with whom I disagree. Like, I don't agree with that smoking should be banned in public housing, for example. I don't really agree with any kind of like abstinent training. Okay. But I'm happy to like talk with people who think that smoking should be banned. Like, that's a conversation we can have. My issue, and you were talking about it with like respecting others. I have an issue speaking respectfully with people who want to deport my friends and their family, who are white supremacists, who support violence against women, and I don't know, or who maybe don't even explicitly support it themselves, but are fine supporting someone who does, as i.e. Donald Trump. So my issue isn't with talking about things where I have disagreements. It's how do I trust someone who's so easily willing to excuse these like egregious abuses of human rights, and how, like, so you have experience, you know, in like talking with your citizens about things that you disagree with like this. So how do you reconcile that? And I guess I don't know who you voted for, I don't need to know, but as a conservative think tank, you have to work with people all day who work with Donald Trump. How do you reconcile that?
No, Josh, why don't you go first and then Brandi?
Sure. I mean, I think it gets to this values-based thing. I mean, this is going to be a stretch, but what is the underlying value of why they are expressing the opinions that they're expressing? And
Donald Trump is white supremacy.
No, hold on. Seriously, just I think like stop in those conversations and try to work with them to get back. And I'm not excusing positions, okay? Let me just be very clear about that. But what I'm saying is that if you want to build the trust, if you genuinely want to build the trust, then you have to take the time to work with them to understand the values-based reason they hold the position that they do. Don't jump to the end conclusion or somebody else that they've been associated with in a position they've taken. Try to understand why they have concerns about immigration. But what is that all about? Okay, and then where is it economic? Is it security? Is it whatever? Those are values that you can then try to work together to say, well, I disagree with you on doing this in response. I think we should do this. But you've at least identified the underlying value to then start from there. I think the problem we have in our country right now is that it's guilt by association in a much stronger way than I've felt, at least in my career, where if you're working within any sort of political environment, then you must endorse all views that are out there. I mean, I'm not sure, let's just take Bernie Sanders, for instance. Do we believe that every person that supports some position of Bernie Sanders supports every single position he holds? Probably not. But they have an underlying value why. So, no, I just think that's what's imperative to this, and I'm not saying that you have to sit down with a white supremacist at dinner every night, but I am saying that if you have somebody in your circle that you genuinely want to move forward with and have a dialogue with, then you've got to start there, finding those values-based positions.
And I think there's two different conversations here. One is how you have this conversation face-to-face with people you disagree with. The second is how you judge what's happening nationally and politically. You're never probably going to sit in front of Donald Trump and ask him what his values are and go there in depth. So it's not necessarily benefit of the doubt, because I think that's probably a poor way to go about it, but it is critically thinking. What are the other reasons why someone could be saying the things that they are? Okay, now I would like to move away from the Donald Trump thing because I don't have any expertise on that and I do not want to go there. So I'd like to talk to you about my experience, okay?
That's why you're here.
Thank you. One of the, which is not that. But one of the things that we've done in our community and with my commission, who doesn't all agree with me, by the way, is to say, let's don't take the baggage from the argument from one issue to the next issue. It's not fair. It's not fair at all. And it kind of goes back to the value-based piece. You value something in this issue, and this other issue you probably value something different, or maybe they're together. Maybe they do align. But when we take that baggage of that tension and that experience of frustration from issue to issue to issue, it shuts us all down. We shut down, and we only see one side of the coin. And so I think it is important. Now, when you hear this conversation and rhetoric coming from someone like me, you imagine to yourself, I'm sure, because I've done this before, that you're just a softie or you don't stand on anything. Well, that is not true about me at all. But what I am willing to do is go there in the conversation. It doesn't mean that I've been manipulated into believing something different than I already do. In fact, I probably could learn something along the way. And let me give you an example since we brought up white supremacy. So last year in my community, there was a big conversation about whether or not the Confederate flag should fly in the Veterans Day parade. So here's what Brandi did. I asked the Sons of the Confederate Veterans to come meet with me and one of my commissioners who was supporting them. And we sat in a room and talked. I got to hear their point of view. And their point of view wasn't necessarily, I'm racist, I'm this, I'm that. It was, this is my heritage. Now, I don't like that argument, and I did not agree with it. And in fact, in some situations, and very kindly, I said, I think you're a little confused, and perhaps maybe you're missing the point. But it started the conversation, and one guy leaned over to me, got very frustrated because I asked him a question. Do you know that your organization is known as a racist organization? I asked that question because the Southern Poverty Law Center has it on their list. And he got really mad at me for asking the question. And finally I said, sir, I'm not here attacking you. This is a legitimate question. I'd like to know how you're thinking about it. How are you thinking that your organization's listed on this list? And so he kind of backed down a little bit. We talked it out. And he invited me to go to the Civil War Museum with him. I said, you know what? Yes, I will go with you. So he gave me a tour of the Civil War Museum. And I engaged in a conversation with him that was uncomfortable, but that was important. And I pushed back on him. We asked questions to each other. And at the end of the day, when we decided that Confederate flag was not going to fly in our Veterans Day parade, one of the most egregious people who was totally against us, who sat in that meeting with me, came up to the podium in our commission meeting and said, I want to thank you. I want to thank you for hearing us. I want to thank you for engaging with us. I want to thank you for being respectful to my position. I don't agree where you landed, but I want to say thank you. And you can imagine in that moment how all of that turmoil that I experienced, hearing something I did not agree with, was worth it. Because we had a conversation about it in my community. And it didn't divide us. We didn't have protests. We didn't have any of that stuff. So I hope that example is enough for you to pull a little bit of insight out. But it's hard work. This is not easy. It is hard work to have a conversation with people that don't agree with you.
Thank you, Brandi. Another question. Anybody? Really? Yes, Dr. Sates.
Thank you. My question's about approaching the role of government, and I think you're right that in public health we often look to government, but I want to ask you about a little bit more about how to think about that. So where I'm coming from is that I think about the role of government when there's something of national, let's say national or community-wide importance. And so we have military that's funded exclusive by the government, right? We don't go to private businesses to fund the military. There are other essential services that we go to government for. And all of public health might not be considered an essential service. So if the idea is to get somebody to exercise a little bit more, maybe that's not an essential service of government to go and force people to do that in some way. On the other hand, if there's a TB outbreak, if we don't get to every single person who has TB, then that will spread through the population. And I'm not sure that private businesses can be a solution to cover everybody. So my question is, is it a more complicated question about when we go to government? In other words, are there times when government probably is the right solution because it hits the whole population, and other times when we shouldn't use that as the first? Or is it never go to government as the first solution? I'm
going to give you kind of a middle-of-the-road answer from my perspective. I think that government should never be your first idea, but it absolutely should be the solution in many cases. So I think what I'm asking for is just a little bit more creative thinking before we default to government. And, you know, I think I can think of many cases where you might think churches could play a very prominent role in education or whatever, and government's helping coordinate that at the end of the day. So it's not that I don't see that there's a role. It's not that I'm trying to privatize everything. I absolutely would agree that there is not a great prioritization often in how we fund things in government. If we want to be really controversial, we can talk about Medicaid expansion. But I think that all I'm asking for from the public health community is before they show up and talk to policymakers that they've done a little bit of legwork to think about others and creative solutions on how to address the problem that they're trying to address in a different way.
And Mayor Harless, you want to comment? Do you find that you can, you know, get things done without always using the government?
Well, I want to say that I think this is, again, a communication issue, because being someone who understands public health and being in government, I know typically how to go find the things that didn't work in the nonprofit sector or the church sector or whatever it is. So that's where I go first to say, is this happening somewhere else? Did it work somewhere else? Oftentimes us as public healthers, when we go to the government, we forget that part of the story. We don't bring it with us. But most of the time it's been done in some way because there's a pilot project that's proven that there's evidence, or there's something that has started somewhere else, because government's too tough to start with, right? We can't start there because it's hard. So I think it's a communication issue possibly that perhaps we need to consider. Let's bring that backstory to the conversation so that when we are going to the government as the solution, it's, well, actually government, sorry, you're not number one, you're like the fifth thing we've tried. And I think that's a really, really important point. Not that, and there's an assumption, I think, that gets had whenever we don't bring that context, that it is the first stop that we're making, is hoping the government. So for me, in my role, I find that I ask that question in lots of other different ways before I bring forward a solution that our government can solve the problem. I believe that the government is the safety net for the most part. I firmly believe that. And that when no one else is doing the work that needs to be done, that's why we come together as a collective to form the government, because no one was paving streets. I mean, we have to come together and pull our resources together. And so I agree with you that priority-based budgeting is a problem. We're actually about to start a huge project in Paducah about performance-based budgeting. So we're measuring if things are working in our government and then putting dollars to that. So I think we have a lot of work to do internally in government to make it more efficient and effective, and I think we would be crazy not to admit that. But it doesn't mean we don't come to the government whenever it's time to implement some things. Yeah.
And the one thing I would add is that there are actually times where the government is the impediment, as in with the needle exchange program. That was the government saying you can't do it. It's not always the government being, sometimes the values and how you label those values can go in both directions. Abstinence-based education. I come from a state where they just passed and I apologize, I can't remember whether it passed the House or the Senate, but it's moving through the legislature, a bill that will require people to opt in. Parents would have to opt in to sex education. Sex education would not be given to your child unless you sign a form saying that you want your child to have sex education. I mean, we also have our state has a high teen pregnancy rate. We have a high infant mortality rate. I'm sure there are plenty of public health experts in this room who would say that's not the way to go.
Well, I think perhaps this is a good place to end, although if people have individual questions, please come forward and talk to the panelists. I'd like to thank them. This is a conversation we can't get away from. There are too many public health problems out there that are not being addressed and that are perhaps being excessively politicized. And I would hope we could find ways to cut through them as simply as Bill Bicknell sometimes did. I will recall here only one quote that some of you who were his students will remember when he said, bad doctors kill people one person at a time, but bad public health kills whole populations. So with that thought, I want to thank our panelists. Thank you very much.